Okay, so I think that this lecture may become very important as you come to the third year and afterwards fourth year, and especially when you later on see patients. ECG is electrocardiogram. It's a very common way to very cheap. It's found everywhere in every emergency room, in every clinic, and it's the best way to quickly diagnose pathologies of the heart and to treat them accordingly. So ECG electrocardiogram is based on the fact that in every given moment, a part of the heart is electrified, so depolarized, and a part of the heart is not yet electrified, so repolarized. And the difference between depolarized part and repolarized part produces voltage. Because what is voltage? You studied physics a bit. Voltage is potential difference between plus and minus. So in every given moment, there is a part of the heart that is depolarized, electrified, and another part which is not yet fully electrified. And this voltage is reflected. It's reflected from the heart on the skin, and it can be graphed in an ECG graph. Let me show you a normal ECG, and then we'll speak a bit about how to connect the leads. This is a normal ECG. Maybe you know it already from physiology lessons. In a normal ECG, ECG is basically a graph. On the y-axis, you have the voltage, the change in voltage, and on the x-axis, you have the time. And then the first normal wave is the P wave. What is the P wave? P wave, which part is electrified first in the heart? The atrial depolarization. So depolarization of the atria, and that's because the SA node, the sinoatrial node, which is electrifying the heart, is found in the atria. So P wave is depolarization of the atria simply because the first part to become electrified are the atria. And then we have the QRS. What is the QRS? Depolarization of the ventricles, because we have first the atria are electrified and then the ventricles are electrified. And between them, we have a segment. We call it the PR interval. It's a time lag because it's the x-axis, right? PR between electrification, depolarization of the atria to depolarization of the ventricles. Why do we have this time lag? Why is the electricity delayed a bit between the atria and the ventricles? Because of what? Because of the... Yeah, but I'm asking why do we have a delay between depolarization of the atria and depolarization of the ventricles? Good, because of the AV node, because the AV node, atrioventricular node, is a bad conductor. So it delays electricity a bit. What do we mean by a bit? What is the normal PR interval? How much time do we have a delay in depolarization between the atria and the ventricle? 0.12 till 0.2 seconds. So again, 0.12 till 0.2 seconds. That's the time lag, that's the delay we have between depolarization of the atria and depolarization of the ventricles. And then we have the T wave. What is the T wave? Good, it's repolarization. So after we have depolarization, we have repolarization because the heart needs to be repolarized in order for it to be able to go through depolarization again. right? So we have depolarization of the atria, time lag, depolarization of the ventricles, and then we have repolarization of the ventricles. And what does it mean, QT interval, from the Q to the T? What's the meaning of this interval? QT, depolarization, repolarization. What happens during the QT interval? Sorry? Yes, depolarization of the ventricle. But what happens when the heart is electrified? It is contracting, good. And cardiac contraction or ventricular contraction is called systole. Systole. So the QT interval is systole. And therefore the TQ interval, so from the T wave to the next Q wave, that would be diastole. Good, good. Which phase is longer, systole or diastole? Diastole, good. Systole is on average in the population 0.35 seconds, and diastole is 0.45 seconds. Both of them together are 0.8 seconds, and that's a cardiac cycle. So this is a normal ECG, P wave, QRS, T wave. How do we connect the leads, and why do we need several leads? So we have the limb leads, we connect the arms, the legs, and we have the chest leads. You can see them here, the limb leads and the precordial or the chest leads. Altogether, we have 12 leads. That's a basic ECG. When you do cardiology, you can also read 18 leads. But why do we need so many leads? Why do we need 12 leads for a normal ECG, to read the ECG? What is the difference between the leads? Okay, good. So the idea is that it gives you different angles over the heart. So when you see an ECG and you see 12 leads, you have the possibility to see the heart from different angles. So I can see the heart, let's say, looking from right to left. That would be see the to say that the heart is suffering from ischemia. It's important to say that there is ischemia in a particular area or particular wall of the heart. This is very important because then when you want to treat the ischemia, for example, when you want to go to the cath lab and open the closed artery, you need to know which artery it is. So you need to know where is the ischemia. And in order to be able to do that, you need to know exactly which part of the heart is suffering. What are we diagnosing with an ECG? So I already told you ischemia. Ischemia can get worse and become myocardial infarction. Myocardial infarction is divided into ST elevation, ST elevation. This is the ST segment. This is the ST segment. So it's divided into ST elevation MI. MI is myocardial infarction. You know what is infarction? Okay, that's the damaged part of the heart. And non-ST elevation MI. So that's one thing that we diagnose with an ECG. Ischemia, when the heart is suffering from low blood supply, or even worse, when it's becoming infarcted. And then we have to differentiate ST elevation MI when we see an elevation of the ST segment or non-ST elevation MI. Why do you think it's so important? Do you know the concept ST elevation MI? Have you heard of it? What is ST elevation compared to non-ST elevation? You understand what I mean, ST elevation, right? When the ST segment is elevated, it's elevated because of what we call current of injury. A part of the heart is injured. So why is it important to differentiate ST elevation from non-ST elevation, MI? You have an idea? An idea? Which one is more dangerous? ST elevation. ST elevation is much more dangerous because ST elevation in MI is a myocardial infarction that is transmural. It means that the entire wall of the heart is damaged. The wall of the heart, let me remind you, is made of endocardium, mid-myocardium, and epicardium. So when you have ST elevation MI, it means that the entire wall of the heart is infarcted. And this is very dangerous. I'll tell you a story. I used to work in the ICCU, in the intensive care cardiac unit. About 1 year before I arrived to the ICCU, there was an enormous tragedy when one of our colleagues, a cardiologist, had chest pain working in the ICCU. He was a physician in the ICCU, a cardiologist, and he had chest pain. And you know, cardiologists, they don't really give too much attention to their health. So he didn't say anything and he continued to work. And the following day, the chest pain became much worse and he collapsed and he had a rupture in the left ventricle. He basically had ST elevation MI that was untreated. And when you have MI of the entire wall of the heart, the danger is that the cardiac wall will rupture. And when this happens, it's basically there was nothing anyone could do for him because the left ventricle ruptured into the pericardium. He had cardiac tamponade, and they did some heroic stuff. They opened his chest, tried to save him on the spot. Imagine it was in the ICCU. It was in the cardiac care unit, intensive cardiac care unit, and no one could save him. So ST elevation MI is a medical emergency. It has to be treated very quickly. Do you know how we treat ST elevation MI? We go to the cath lab. We go to the catheterization lab. We go from the radial artery all the way to the heart, and we opened if possible, of course, we opened the obstructed artery. So ST elevation MI is one of the most prominent cardiac emergencies, have to be treated very carefully, very quickly. And I can tell you that in Israel, there is a competition between the hospitals. Which hospital is the quickest in treating ST elevation MI? And where I worked, we were number one for many years because from the moment that the patient was reported to arrive to the hospital until a full treatment, it was 37 minutes. 37 minutes. And in Israel, we say, in medicine, we say, time is myocard. So we have to work very quickly in order to save the myocardial tissue. So one of the things that we do, one of the things that can be easily diagnosed is myocardial infarction. ST elevation MI is the most dangerous. Non-ST elevation MI is dangerous. You have to hospitalize the patient. The patient has to be monitored, but the patient can wait up to 24 hours until going to the cath lab. So this is not an emergency. You don't have to call physicians from home to open a cath lab and to treat the patient. But ST elevation MI is extremely, extremely important. And the thing with using 12 leads ECG is that we can say, okay, this patient has myocardial infarction, and we can also say which artery is infarcted. If it's the left artery or the right artery or the inferior artery, we can we can produce a very clear and reliable image of which part of the heart is damaged. So one thing that we can diagnose with an ECG is ischemia and infarction. What else can we diagnose with an ECG? Sorry? Arrhythmia, good, arrhythmia. That's another thing that we can diagnose. And arrhythmia it's very evident clinically where you have patients coming, they don't feel well. Which ischemia, which arrhythmia do you know? Good. So first you can divide it by the rate. It can be bradycardia, so slow heart rate, and it can be tachycardia, so fast heart rate. What's the normal heart rate? 60 to 90. So below 60, that would be bradycardic patient. Above 90, above 100, that will be tachycardic patient. And you can also divide it according to where the pace is coming from. So it can be, we crudely divide it into supraventricular tachycardia coming from the atria or ventricular tachycardia. Which one is more dangerous? The ventricular tachycardia, of course, is more dangerous because it can develop to what? Ventricular tachycardia can develop into what? Into ventricular fibrillation, which is lethal unless treated very quickly with, what do we do in case of ventricular fibrillation? Electric shock. Good. It has to be, we have to use a defibrillator in order to shock the heart, in order to, and that's the only way to save a patient. I can tell you a story when I worked in a cardiac unit, in a cardiac clinic. I had a patient, 67 years old, coming to me all gray, saying I have chest pain. And I immediately connected him to a monitor, and it showed ST elevation MI, which quickly developed into ventricular tachycardia, ventricular fibrillation. And he was like, in 2 minutes, he was unconscious and practically died because he had no pulse, ventricular fibrillation. It means that there is a, like we call it like an electric storm in the heart. Instead of contracting very orderly, the heart is contracting like this. This is ventricular fibrillation. And the only way to save the patient is to give him electric shock, but the defibrillator didn't work. So it was a very, very intense moment. His wife was with him. She was yelling, shouting, why it's not working. I sent someone, in 30 seconds, I had another device. I gave him 2 shocks and he's still alive. So that's the only way to save a patient. And when someone has ventricular fibrillation, we basically have 10 minutes to save the patient. And we say very, again, crudely, we say that every minute, the chances of survival are decreasing by 10%. So if you give the shock within the first minute of ventricular fibrillation, you have more than 90% success rate. If you'll come after 5 minutes, you have 50% success rate. So it's very important to diagnose quickly and to treat very quickly. So the most important things that we diagnose with an ECG is ischemia and arrhythmia. But we can also diagnose congenital abnormalities like dextrocardia, when the heart is flipped within the chest wall, like Brugada syndrome, genetic syndrome like WPW, Wolff-Parkinson-White syndrome, which is causing tachycardia. So we can diagnose genetic or inborn abnormalities. One of the most dangerous abnormalities that we can easily diagnose with an ECG is long QT syndrome. Have you heard of it? Long QT syndrome. where you have the QT syndrome. That's from the beginning of the Q till the end of the T. QT syndrome, which should be around, let's say, 0.5 seconds. When it's prolonged, it can be very dangerous. And the danger is when it's becoming 0.6, 0.7 seconds, the danger is that the QRS, the next QRS, will fall on the T. And we call it R on T, or to set the point. And this patient will 100% will develop ventricular fibrillation and die. And we often, maybe not so often, but we relatively often see it in children, long QT. And you know what we do with patients that have long QT? What's the only thing we can offer them? Let's say a child is coming, it is not feeling well, and is, let's say, accidentally diagnosed with a long QT syndrome. What can we offer this child, 12-year-old child, in order to save his life? We offer implanted defibrillator. So this child has to live with a defibrillator throughout his life, so that if he has an arrhythmia, it will be shocked immediately. And these things can be easily diagnosed with an ECG, and it doesn't cost anything, and it's very common. You can find it everywhere. So this is, for my opinion, by far the most important tool that we have as physicians, even as medical students, because as medical students, you will do clinical rotations, and during the clinical rotations, you will see patients. And when you'll see patients, sometimes you can even advise and you can even diagnose. And ECG is a very simple and very common tool to use. How do we interpret ECG? So when you look on an ECG, the most important thing is first to say, and the most obvious thing is the heart rate. Every small square in an ECG graph is 0.2 seconds. So you can easily see if the patient has a normal heart rate, if the patient is tachycardic or bradycardic. So the rate is the simplest thing that you can very easily see and diagnose. Then comes the rhythm. What does it mean, rhythm, in an ECG? What's the normal rhythm? So the normal rhythm would be sinus, right? Sinus rhythm. Because you remember that the conductive system of the heart starts with the sinus, with the SA node, right? And then it goes down to the atria, AV node, then bundle of His, right and left bundle branch, and Purkinje fibers. You remember that? Okay, so let's say the normal rhythm will come from the sinus. But if not sinus, you can at least say that it's atrial rhythm. It comes from the atria. Otherwise, it can come from the node, then we call it nodal rhythm. And it can, in some cases, come from the ventricles, because the heart has this mechanism where if you have a non-functional sinus node, then the AV node can take over and it can pace the heart. And if the AV node is not functioning, then below it, you have the bundle of His that can take over and pace the heart, electrify the heart. And if this is not working, you can go down to the ventricles, and then you have ventricular rhythm. So the heart has a survival mechanism where if a superior part of the heart is not working, beneath it, the heart can survive by pacing itself on a lower rhythm. But it's very important to diagnose the rhythm. Then we have the axis of the heart. Have you heard of the axis of the heart? Here you can see the normal cardiac axis here. So normal axis is from -30 to +90 degrees. And if it goes, you see the pink part, the normal axis. And if it's below -30, then it's left axis deviation. And if it's more than 90, then it's right axis deviation. Why does it happen? Why would we have a deviation in the axis of the heart? Okay, that's one way. One example is that the actual axis of the heart is changing because let's say if someone is very obese, then you're saying the diagram is pushing the heart upward and the heart is becoming, the angle of the heart is changing. But this is not so common. When we speak about arrhythmia, what can be a cause of axis deviation, which has clinical meaning? Have you heard of hypertrophy of the heart? When the cardiac wall is becoming thicker, this is very, very important because when you have right axis deviation with additional criteria, you can diagnose right ventricular hypertrophy. And we have left axis deviation, you can diagnose left ventricular hypertrophy. Why would we have right or left ventricular hypertrophy? Why would the heart become thicker? What's the normal thickness of the heart of the let's start with the right ventricle. Around up to let's say 4 millimeters, and the left ventricle would be up to 11 millimeters. Why is the left ventricle thicker? Why is the left ventricle thicker? Right, because it's delivering blood to the whole body, and the right ventricle is delivering blood only to the lungs, right, which are closed, and the pressure is much lower. So the left ventricle, as it is thicker than the right ventricle. But then you may have hypertrophy of the left ventricle. Why would we have hypertrophy of the left ventricle? Sorry? Good. Hypertension, high blood pressure, because the heart is delivering blood to the body and it has to open which valve? In order to deliver blood to the body, which valve has to be opened? The aortic valve, right? And if you have high blood pressure, then the opening pressure of the aortic valve is higher. And in that case, the heart has to work harder. And that's why you may have hypertrophy of the left ventricle. Why would you have hypertrophy of the right ventricle? Hypertrophy of the right ventricle. Similar reason, only coming from the lungs. We have one very bad situation that is called pulmonary hypertension. Pulmonary hypertension, when there is hypertension within the arteries of the lungs, and this may cause ventricular hypertrophy, right ventricular hypertrophy, which is very important to diagnose. So with the cardiac axis, you can diagnose left and right hypertrophy of the heart. What else could be a reason for left axis deviation or right axis deviation? At the end, think about it, we're speaking about electricity, right? It's electricity. So why would we have left or right axis deviation? Because of a delay in the polarization. And this delay can be due to blocks. For example, right bundle branch block. Have you heard of right bundle branch block? You know the right bundle branch coming from the His bundle? So the right bundle branch, when it is blocked, it's not necessary, but it can come with a right axis deviation. because the electricity is blocked, it's delayed. So there is an axis deviation of the electricity. Because imagine at the end, you don't see the heart, you see the electricity flowing through the heart. So when you have right axis deviation, it can be due to RBBB, right bundle branch block. And when you have left axis deviation, it can be due to LBBB, left bundle branch block, which is also very easily diagnosed in an ECG. So the axis of the heart is the next thing that we're checking. We said rate, rhythm, axis. Then we look on the intervals. Remember we mentioned the intervals? PR interval, QT interval, TQ interval. So we look at the intervals and the QRS, of course. Why would we have a prolonged PR interval? PR interval. I remind you, PR is a delay in depolarization because the AV node is a bad conductor. So why would we have a delay in the PR interval, a longer PR interval, more than 0.2 seconds? Because of? No, it's very simple, actually. Why would we have a prolonged PR interval? Remember, the PR is the conduction of electricity through the AV node. So why would we have a prolonged PR interval? Because of AV block. AV block. Remember, the AV node is a bad conductor. It doesn't conduct electricity very well. It's delaying the electrical pulse coming from the atria to the ventricle. Sometimes the conductivity of the AV node can become worse, especially with age. And then we call it AV block. AV block. There is a delay in the depolarization wave from the atria to the ventricle. And this AV block have several levels. It can be first degree AV block. You don't have to do anything. Second degree AV block, type 1 and type 2. Type 2 requires a pacemaker. And then you have third degree AV block, which is a complete AV block. There is no synchronization between the atria and the ventricle. And this patient must have a pacemaker. Otherwise, he will die. I had a patient, 40 something, very young, walking into the emergency room with his family, walking into the emergency room, laughing with the family, doesn't feel so well. We did ECG. We found third degree AV block, which was compensated by the ventricles. So this patient would walk, would speak, but then after several minutes, he collapsed. And one of the things that we're doing in the emergency room is we are inserting through the jugular vein a pacemaker. So we did it. We successfully inserted a pacemaker through the jugular vein all the way to the heart, but the patient couldn't be saved. We don't know why. We successfully electrified the heart, but the patient died. And imagine a 40-something, very young patient coming to the emergency room with his family, walking, laughing. After 5-6 minutes, he's dying. He's dead. So that's cardiology. Sometimes you are able to save, and I can tell you that cardiology is all about life saving on a daily basis. But sometimes we are not able to save, and we don't even know why. We did everything correctly. We paced the patient, but the patient died. So this is just an example. So we said rate, rhythm, axis, intervals. What's the meaning of the QRS interval? It should be below QRS, repolarization of the ventricles. Should be below. Good, 0.12, 0.12. If it's more than 0.12, it could mean several things. It could, as an example, mean right bundle branch block when it's on the right leads. or left bundle branch block when it's on the left leads. So QRS, the duration of the QRS is very important. Has to be below 0.12. Very good. Then we have the QT interval, which is systole. Why would we have a prolonged QT interval? What could be the meaning? What could be the reason of a prolonged QT interval? QT, prolonged QT is extremely dangerous. So remember we said genetic prolonged QT interval, that's one reason. Another reason is drugs. Drugs, I mean medications, not drugs, but medications. Like, for example, amiodarone, which is an antiarrhythmic drug that we're using, can prolong QT interval, which is very, very dangerous. It can easily develop into ventricular fibrillation. So QT interval prolongation. And we can also have a short QT interval. Why would we have a short Q interval? QT interval, that's systole. Can you think of a reason why would we have a short QT interval? Something with electrolytes? Which ion is essential for cardiac contraction? Calcium, good. So hypercalcemia, high calcium level in the blood can result in a short QT interval. When you have hypercalcemia, systole is becoming shorter. And this can be diagnosed with an ECG. And when you speak of the T wave is repolarization of the heart. Which ion is responsible for repolarization of the heart? So depolarization is the entry of sodium into the cell, right? And then repolarization is because what goes out? Which ion? Which? Potassium. Good, potassium. So hyperkalemia, which is which is extremely dangerous, can be diagnosed with an ECG. When you have a notched T wave, and I'll show you examples, when you have a notched T wave, it can mean a very high level of potassium in the blood. And this is also a medical emergency. Because it can cause cardiac block. And it can be treated easily with diet modifying and modification and such. But if it's very high, sometimes we have to use dialysis. We have to clear the blood from potassium. So electrolytes, calcium, potassium, the level of electrolytes can also be reflected on an ECG. So we said rate, rhythm, axis, interval, and of course the ST segment that I mentioned. ST segment can be elevated, as we mentioned, ST elevation MI can be, the T wave can be reversed, which would mean ischemia. ST segment, when you're thinking of the ST segment, think of blood supply. ST segment would mean blood supply. When you have a modification, a change in ST segments, either a reversed T or elevated ST, that would mean very bad things. That would mean acute coronary syndrome, which has to be treated very, very quickly, as we mentioned before. Okay, so here you can see a normal ECG, and you can see all the pathologies that we have mentioned. Okay. Let me show you two ECGs. Let me show you examples of ECGs that are reflecting everything that the pathological ECGs that we mentioned before. So the first one here, you can see an LBBB, left bundle branch block, which it's not uncommon to see, especially when you work in the ICCU, you see it on a daily basis. So what we see here, this is lead number 1, 2, 3. Then you have V1, V2, V3, V4, V5, V6. And here you have AVL, AVF, AVR, and you have a stripe of ECG. So first of all, we divide the leads into areas. Before we'll start with the LBBB. Remember and write it to yourself because this is important. Leads number 2, 3, and AVF, that's the inferior leads. It's like cameras looking over the inferior posterior part of the heart. Lead number 2, 3, AVF. That would be, you see, 2, 3, AVF. This will be the inferior posterior part of the heart. Then you have the left lateral leads. That would be lead number 1. You see it here. AVL, you see it here. V5 and V6. So remember, 1, AVL, V5, V6. That's the left lateral leads of the heart. Then you have the V1 to V4. You see V1, V2, V3, V4. These would be the anterior leads. That will give you a reflection. It's like a camera looking on the anterior part of the heart. So there you have a whole coverage of the heart. Again, leads 2, 3, AVF, inferior posterior part of the heart. Leads 1, AVL, V5, V6. That will be the left lateral part of the heart. Then you have V1, V2, V3, V4. These are the anterior leads, looking on the anterior part of the heart. Okay, that's how we divide the ECG. Now, when we look on this ECG, let's start to analyze it one step at a time, as we mentioned before. We start with the rate. And I told you that every square here is 0.2 seconds. 0.2 seconds. So 5 squares will be 1 second, right? And the normal heart rate should be 5 squares between R to R, because we expect 1 second, 1 heartbeat, 1 second, another heartbeat, 1 second, another heartbeat. That will be 60 beats per minute, right? So if you have heartbeat, and then after 1 square, after 0.2 seconds, you have another heartbeat, what would be the rate then? What is the rate? If the difference between R to R is 0.2 seconds. So again, if the R to R difference is 1 second, the heartbeat is 60 beats per minute. But if the difference is 0.2 seconds, the heartbeat is 300 beats per minute. Good, remember that. 1 square, that will be 300 beats per minute. Very, very severe tachycardia. When you have 2 squares, that will be 2 squares between R to R, that would be 150. Remember, 50. How much? How many? 0.2 seconds. If you have 3 squares, that's 0.6 seconds. So what's the heart rate? 0.6 seconds from R to R. So what's the heart rate? It's 100 beats per minute. Remember, 1 square, 300. 2 squares, 150. 3 squares, 100. 4 squares, 75. 5 squares, 60 beats per minute. Again, 1 square would be 300 beats per minute. 2 squares, 150. 3 squares, 100. 4 squares, 75. 5 squares, you have a normal 60 beats per minute rate. So in our ECG, you can see 1, 2, 3. It's around 100 beats per minute, even a bit more. 100, 110 beats per minute. So this patient is tachycardic. Good. Tachycardic. Good. Now let's speak about the rhythm. Do you see P waves? Do you see P waves before a QRS? P waves? Let's look for P waves. P waves. Look, you see here in V1, P QRS, P QRS, P QRS. Do you see that? P, you don't see it in every lead, but in V1, you can see that you have P waves. It means that the rhythm is sinus, or at least atrial rhythm. So we say, okay, we have a tachycardia, we have sinus, because we found P waves. Again, look at V1, P QRS, P QRS, P QRS. So it means that even though we have tachycardia, we can see a P before every QRS. So we have sinus rhythm, we have tachycardia, 110. Okay, what's the axis? I'll give you a very, maybe you heard it before. I'll give you a very simple way to see the axis immediately. Normal axis means positive wave on the first lead and a positive wave on AVF. Again, positive first, let me show you. A normal axis would be, you see, this is lead 1, this is AVF. As long as 1 is positive, and AVF is positive, you are sure to have a normal QRS axis. You see? But if AVF is negative, here, and 1 is positive, that would be, again, positive and positive, normal axis. AVF is negative, you see here, and 1 is positive. That would be left axis deviation. You see? This is left axis deviation. If AVF is positive and 1 is negative, that would be right axis deviation. Remember, write it to yourself. It's very easy. When you look on an ECG, when you have a positive wave on the first lead, positive AVF, for sure it's a normal axis. Positive first, negative AVF, it's a left axis deviation. You see? Positive first lead, negative F, left axis deviation. If you have a positive AVF, negative 1, that's a right axis deviation. So with AVF and 1, you can easily calculate the axis of the heart. Now, on a clinical perspective, it's not really important to say if the axis is minus 90 or plus 80 or what's the exact axis. You just need to say if you have an axis deviation or if it's a normal axis. So remember what we said. Let's see our ECG. Okay, 1 is positive. You see, 1 is positive. AVF is positive. You see, it's a positive wave. Positive, above 0. So 1 is positive. AVF is positive. It means that we have a normal axis. Okay, so we said the rate is around 110. The rhythm is sinus. The rate The axis is normal. What comes next? The intervals. Do you remember the intervals? The PR interval, is it okay? From P to R. Is it normal? Is it below 0.2? Below 1 square? Shorter than 1 square? Look, from the P, choose one P. From here to the R, is it below? Is it shorter than 1 square? What do you see? From the P to the R, this interval, is it shorter than 1 square? Then it's normal, right? What about the QRS? QRS. QRS. Look at the first thing. The QRS is very prolonged. So the QRS, which you mentioned correctly, should be below 0.12, is around 0.16. The QRS is prolonged. So we start thinking about maybe we have a bundle branch block. QRS prolonged, it can be because of a bundle branch block. Now, when you see, remember, when you see a QRS duration of more than 120, immediately you think of a bundle branch block. When you see a very prominent R, you see here on the first lead, and a very deep S on V1, this is a very clear indication of LBBB, left bundle branch block. Again, wide QRS, we have here a very prominent R on the first lead, a very prominent S on V1. This is an indication of left bundle branch block, LBBB. I remind you, left bundle branch is branching from bundle of His, right? We have the AV node, bundle of His, then we have the right bundle branch and the left bundle branch, right? So when you have a left bundle branch block, it comes from the bundle of His. What could be a reason for a patient to have a left bundle branch block? Why would someone come to the hospital with LBBB? What do you think? What's the most common reason for a new LBBB, left bundle branch block? Guess. I mean, maybe you don't know, but you can guess. What can be a reason for a new LBBB? I'll give you a hint. A new LBBB is a medical emergency. Has to be hospitalized, has to go to the cath lab immediately. What can be a reason for a new LBBB? Sorry? Heart attack. Good. Myocardial infarction. So think of it. It's electricity. Why would electricity stop, or why would electricity be delayed? Electricity is delayed because there is a damage to the tissue. And what is the most common reason for a damage to the tissue? Ischemia. Ischemia or myocardial infarction. And remember what I tell you now, a newly diagnosed LBBB plus pulmonary edema. You know what is pulmonary edema? Where you have fluids in the lungs. Fluids in the lungs. A newly diagnosed LBBB plus pulmonary edema equals ST elevation MI. Remember that. This is very important. We once had a patient in the ICCU, in the emergency care unit, a patient that came with a newly diagnosed LBBB. He was 60 something with pulmonary edema. And the physician that was there this night, he didn't remember that it equals ST elevation MI. And the patient died after 2 hours. And he could be saved. He could be saved. He just needed to go through the cath lab. So you see in cardiology, every decision can be life or death. This is something that you need to consider if you're choosing cardiology. So a newly diagnosed LBBB plus pulmonary edema is a medical emergency. It's the same as ST elevation MI. Remember I told you ST elevation MI? It means that there is a damage to the entire wall of the heart. And this has to be treated immediately. Okay, let's see another one. Let's analyze this one. Okay. So let's start with the rate. What's the rate here? Remember, 300, 150, 100, 75, 60. So what's the rate here? Around. Let's choose this. Okay, we can start with here because it's on the line basically. So 300, 150, 100, 75. So it's around 80. Heart rate is around 80, which is okay. It's within normal limit. It's not tachycardia, right? Okay, what's the rhythm? Do you see P waves before the QRS? Yes, yes, you see? P wave, QRS, P wave, QRS, P wave, QRS, P wave, QRS. So the rhythm is sinus rhythm. So we have normal rate and we have sinus rhythm. Good. What do we do next? Rate, rhythm, axis. Good. What about the axis? Lead one is positive. AVF is isoelectric. What does it mean, isoelectric? It means that you have an R wave and an S wave with the same magnitude. You see, AVF is not, the net AVF is not positive and not negative because you have a positive wave here and you have an equal negative. R and S are equal. It means a slight left axis deviation, but within normal limits. Okay, so we have sinus wave, normal rate, normal axis with a slight left axis deviation. What comes next? The intervals. What about the intervals? The PR interval from the P to the R. Is it less than one small square? Yes. So PR interval is normal, right? Okay. Then we have the QRS. Is the QRS normal? No, it's wide. The QRS is around, you see, from the Q to the end of the S, it's around 0.15. It's a wide QRS. So when we see a wide QRS, we are thinking maybe we have a bundle branch block. That's the way you need to think. Either a right or a left bundle branch block. When you see on V1, remember, when you see on V1 RSR complex, you see on V1 RSR complex. You see what I'm showing you? You have R, then an S, then an R. RSR complex on V1, it's a diagnosis of right bundle branch block. Right bundle branch block. So this ECG is right bundle branch block, RBBB. Again, rate is normal. Rhythm, sinus. Axis, slight left axis deviation. On V1, I see an RSR complex. That's a diagnosis of RBBB, right bundle branch block. Now, something to remember for the future. The right bundle branch is receiving the same blood supply as the left anterior bundle branch, because the left bundle branch is divided into anterior and posterior. Very frequently, when we have RBBB, we also have left anterior hemiblock. Remember this, if you're writing note, this can be important. In this case, we have RBBB plus left axis deviation. It means RBBB plus left anterior hemiblock. That's the diagnosis. Okay, let's see what we have. Let's see what we have here. Okay, let's look on this ECG. Try to do it yourself. Rate, rhythm, axis, intervals, segments. Try to do it yourself. Try to diagnose this patient. This patient is asymptomatic. So it's normal. It's a normal patient coming for, and this is accidental finding. You want to try? Anyone? Step by step. You want to try? No? Why? Let's try. Heart rate. You can choose. Here it's very obvious. 300, 150, 100, 75, somewhere between 60 to 75. So this is a normal heart rate, right? Normal heart rate. Okay, so let's say that the heart rate is around 65, 67. What about the rhythm? Not sinus? Why? Look, you have P QRS, P QRS, P QRS, P QRS. You see, you have a P wave before every QRS. So this is a sinus rhythm. Okay, so we have normal heart rate, sinus rhythm. What about the axis? Axis is normal because one first lead is positive, AVF is positive, so it's a normal axis. Good. So we have normal heart rate, normal rhythm, atrial rhythm. We have normal axis. What about the intervals? Good. What is the PR interval? You see, this is a P wave. This is QRS. Do you see that it's longer than 0.2 seconds? So this is a first degree AV block. First degree AV block. It means that the PR interval below 0.2 is more than 0.2. It's around 0.25 seconds. It's a first degree AV block. That's the diagnosis of this patient. Why would someone have a first degree AV block? In many cases, due to age. Because the AV block, remember, is anyway a bad conductor and it's becoming worse with age. So this is a first degree AV block. That's the diagnosis. You already diagnosed LBBB, RBBB, AV block. Okay? Is everything clear? Good. Okay. This is a very nice example of second degree AV block. AV block, if you remember, I told you, AV block can be very dangerous. Remember my story about the 40-something person coming to the emergency room walking and then he died after 5-10 minutes. So AV block can be very tricky. Here you see second degree AV block is divided into Mobitz 1 and Mobitz 2. Mobitz 1 is when you have prolongation of the PR interval. You see PR interval, second PR interval, third PR interval. Do you see that the PR interval is becoming longer? So look here, PR interval, normal, PR interval, longer, PR interval, very long, and then you have a dropped beat. This is what we call Wenkebach. Wenkebach or Mobitz 1 is where you have a prolongation, consequent prolongation of the PR interval until you have a drop beat. This is Mobitz 1, still doesn't require a pacemaker. Okay, it's very important to diagnose because this patient most likely will need a pacemaker in several years. But Wenkebach, Mobitz 1 is not an indication for a pacemaker. Okay? This is Mobitz 2. Mobitz 2 is where you have a constant PR interval with a dropped beat. You see, normal PR interval, normal PR interval, normal PR interval, and then you have a dropped beat. This is Mobitz 2. This is already an indication to a pacemaker. And this is extremely important to diagnose, and it's not so easy to diagnose. And the patients can be completely asymptomatic. A personal story I have is about my father. He was asymptomatic, feeling well. One day he had some dizziness or something, sent an ECG to his physician, and the physician did not diagnose Mobitz 2. And then when I looked on the ECG, I came to visit them, and I looked on the ECG, I saw the Mobitz 2 the day after he had a pacemaker. And that's life-saving. Because remember, when it's becoming complete AV block is sometimes not possible to save. Sometimes we do save a complete AV block, but it's not obvious that the patient will be saved. Mobitz 2 is one step from a complete AV block. So you see the difference? Mobitz 1, remember, is just a prolonged PR interval. Mobitz 2, AV block, type 1, first degree, just a prolonged PR interval. Second degree, Mobitz 1, the PR interval is becoming longer until you have a dropped beat. Mobitz 2, second degree, the PR interval is constant, then you have a drop beat. This is an indication for a pacemaker. Okay, what do we have here? Here we have an example of a third degree AV block. Third degree AV block, you can already see that the patient is very bradycardic. You see, that's a third degree AV block. Look on the difference between R to R. The patient is very bradycardic. This patient has like a 25 or 30 heartbeats per minute. So this patient obviously is not feeling well. One of the things that will help you with the third degree AV block, you see that there is no connection between the P and the QRS. Look here, you have like a P wave, P wave, P wave, P wave, P wave, and these P waves are not connected to the QRS. It's like you have an independent activity of the atria, and it's asynchronized to the activity of the ventricles. This is a third degree AV block, extremely dangerous. The only way to save the patient is with a pacemaker. And as I told you, it's not always working. Okay. Here is a nice summary of AV block. Normal, first degree, second degree, third degree, complete AV block. You mean when you have a complete AV block? When you have a complete AV block, you see a separate activity of the atria, and you see a separate pacing of the ventricles. So the ventricles are taking over, but it's a very slow heart rate. Let's say that if the sinus is the SA node is producing, let's say 80 beats per minute, the AV node is producing 50 beats per minute, the ventricles are producing 25, 30 beats per minute. So the idea that you will be able to survive, but you feel terrible and you have to have a pacemaker. Okay. This is a very interesting ECG. Let's see. Okay, this is what I wanted to show you. This is ventricular fibrillation. Ventricular fibrillation is what we call an electric storm. So you see that the activity is completely chaotic. There is no order. There is no atria ventricle, PQRS, PQRS. Instead, you have this mess. So the heart is fibrillating. It's not really contracting. And you don't have a pulse. You don't have a peripheral pulse. This patient needs to be treated with electric shock defibrillator. Yes. This is also a nice story. Let's look on this ECG. We're about to finish this part of the lecture. Where you have a patient on a reasonable shape coming to you with strange feeling in his chest. So it's not really a typical chest pain. It's strange feeling in the chest. Usually it's young patients. So you're not necessarily suspecting myocardial infarction. Let's say you have a 16, 17, 18 years old person. Not likely that this person has myocardial infarction and is coming with an uncomfortable feeling in his chest. And this person is much, much more relieved when he's leaning forward. So when he's leaning backward, he feels bad, but when he's leaning forward, he's relieved. Do you have any idea what can be a reason for such a clinical presentation of a patient? He's telling you that he had a viral infection 2-3 weeks ago, throat pain, running nose, and now he's coming with this strange feeling in his chest. No. The person is feeling fine. I mean, he's feeling okay, but he has this uncomfortable feeling in the chest, post-viral infection. This can also be quite. It's not, yeah, angina pectoris is related to acute coronary syndrome that we see in older age. This person is 18 years old. It's not likely that he has an ischemic event. And he's post-viral, and he has this strange feeling in the chest, and he's relieved. Remember this, he's relieved when leaning forward. So it's an inflammation, and do you know which inflammation it can be? Inflammation of what? Of the pericardium. Usually it's inflammation of the pericardium, what we call pericarditis. Pericarditis, remember, pericarditis you see mainly in, not only, but mainly in younger patients, post-viral, uncomfortable feeling in the chest, and a very bad looking ECG. You see this ECG, one of the things that you see in this ECG, that you have ST elevation. You see this ST elevation in the first lead? ST elevation here. You see ST elevation in the second lead. You see ST elevation in AVF. You see ST elevation in V4. in V5, you see these ST elevations? Now, when we see a diffused ST elevation, so you have ST elevation in the anterior leads, in the lateral leads, in the inferior leads, it's very unlikely that this is an ischemic event because a person doesn't have ischemia throughout the entire heart. Normally, the ischemia is in a certain arterial area, left, right, inferior, etc. But here you have a diffused ST changes. And the reason for it, this is a diagnostic ECG for pericarditis. Pericarditis, remember, diffused ST elevation. You can also look at it as a lower PR segment. You see that the PR segment is lower than the ST? You see here, PR segment lower than the ST? This is a PR, this is a decrease in the PR segment or elevation in the ST segment because they are relative to one another. This is a diagnosis of pericarditis. Pericarditis, inflammation of the pericardium. Remember, post-viral, young patient, diffused ST elevation or PR decrease, PR segment decrease, and when he's leaning forward, he's much relieved. This is the diagnosis of pericarditis. Pericarditis is not necessarily dangerous, but it can develop into myocarditis. You know the difference? Pericarditis, inflammation of the pericardium, right? Myocarditis, inflammation of the heart. And myocarditis can be lethal, can be very, very dangerous. So myocarditis, some patients skip out of it with nothing. Some patients die from it. This is a medical emergency. Myocarditis can develop from pericarditis and it can become very dangerous. So remember, with ECG, we are diagnosing not only ischemia and arrhythmia, we can also diagnose inflammation. Inflammation of the pericardium, inflammation of the heart. Here you see an example of a long QT. Remember, I told you that long QT can be very, very dangerous. So look, from Q to T, you see 1, 2, 3 squares. That's 0.6, 0.6 seconds. Long QT syndrome. Long QT syndrome, when someone has a sudden death in the family, and that's one thing that physicians will always ask you. If someone has a sudden death case in the family, especially of a child, but a sudden death, usually very tragic stories of a sudden death in the family, the whole family needs to go through an examination for a long QT syndrome because death can be easily prevented by defibrillator implantation. Okay, what you see here, and with this, I think that we can finish for today. What you see here is maybe you'll know. Maybe you'll know yourself. What do you see here? Let's look at this as ECG, and with this, we can finish for today. Let's start with the basics. Let's start with the heart rate. What's the heart rate here? Heart rate. Let's see. Let's take this one to the starting point because it's right on the line. So 300, 150, 175. It's around 80. It's around 80. Okay. So this is a normal heart rate. What about the rhythm? Sinus, not sinus? Yes, sinus. What is it? Do you see P wave before every QRS? So this is sinus. Sinus rhythm. You see PQRS, PQRS, PQRS. This is the sinus rhythm. So we have normal rate, we have normal rhythm. What about the axis? What do you think? Normal? Let's see. One is positive, right? But AVF is negative. You see that the AVF has a prominent S wave and a less prominent R wave. So if AVF is negative and one is positive, this is a left axis deviation. So we clearly have here a left axis deviation. Let's look on the segments and intervals. One of the very clear things that we can see here with the ST segment is this is ST elevation. You see the first ST elevation, AVL ST elevation, B5, B6 ST elevation. This is an ST elevation mark. ST elevation, myocardial infarction in the left lateral leads. Most likely, there is an obstruction in the left anterior descending artery or the left circumflex artery. So when a cardiologist is looking on this ECG, he knows that this patient has ST elevation MI, and he knows where, in which part of the heart. Okay, I think that's it for today. I hope it was interesting for you. Tomorrow I'm having another lecture and we can go over more examples of ECG if you have time, and then also on Monday.